Welcome back to the Femme FC Podcast. I'm really excited for today's episode with Dr. Jon Drezner. I was lucky enough to work with Jon while I was at Seattle Reign. Jon is also team physician for Seattle Seahawks, who just won the Super Bowl. He's the editor-in-chief of the British Journal of Sports Medicine, director of University of Washington Medicine Center for Sports Cardiology, and has been a huge mentor and help for me over the course of my career ever since stepping into professional sport. So I'm really excited to hear from Jon, catch up with him, and have you all learn from him as well. So Jon, thanks so much for joining us. I'm really excited to chat with you.
It's great to see you, Nicole, and great to be here. Thanks for having me on the podcast.
Of course. Would you mind just sharing a little bit about your background and how you got into sports medicine and sports cardiology specifically?
Sure. So I originally trained in family medicine and did a fellowship in sports medicine. Early on, I had an interest in heart issues in athletes, probably dating back to some very public sudden cardiac death events that occurred when I was in college. And loved my cardiology rotation in medical school, and really as I entered fellowship had an interest in prevention of sudden cardiac death in athletes, and that's sort of where my first academic endeavors started, and some of the research began in that space. At the University of Washington, I've been really lucky to work with some great people, and in 2014 we started the Center for Sports Cardiology, which is a nice collaboration between both sports medicine and our division of cardiology. So, the cardiovascular care of athletes of all ages really is multidisciplinary, and everyone can have a role. And I think we've expanded the roles that, let's say, team physicians and sports medicine physicians may take, but we do that hand in hand with our cardiology team, and I'm just grateful for everything that I've learned along the way.
And from your experience in various settings in elite sport, why is sports cardiology a topic that's so important for support staff to understand, and why is it so important for us to learn about and continue to study?
Yeah, that's a really important question. And I would say that heart issues in athletes, while generally infrequent, are probably the single most important thing that people need to be aware of. Because if something occurs in front of you, you have to know how to respond and be prepared to respond, or a tragedy unfolds. And when someone does have a sudden cardiac arrest, death is preventable if you're prepared. And so, we've all heard about the tragedies that occur, the incidents that are totally in public view, from Christian Eriksen to Damar to even Bronny, et cetera. But it's not just those athletes. We have athletes of all ages, both sexes, collegiate, high school, youth levels that are having these events. And, for me, as a primary care physician, prevention is critical. But in my role as a sports medicine and team physician, if I can't take care of this one aspect of my job, which is make sure athletes are safe to do what they love to do, and make sure that no one's going to have an arrest, or if they do have an arrest, that I'm prepared on the field of play, then I'm not sure what else I'm doing. And so, I know that for athletic trainers, this is top of mind. Everybody has to, have that emergency action plan. It's the requirements about how frequently you practice it, who should be involved in those practices, et cetera. But if you're a physical therapist and you're on the sideline, or you're working with people on the field, as they, return to play, if you're a strength and conditioning coach and you're the only, sort of adult or staff member around when they're having their training or conditioning, if you're just a sports science professional and you're doing some of the monitoring, like if you're the only one around, you have to know this topic. Like, this is important. And you have to know both, what are the potential causes? What are those signs? If they do have an arrest, what does it look like? Now, what do I do in the setting of an emergency, and how I can prepare for that? So I think this is a checkbox for everybody who works with athletes. They have to know this area.
Yeah, I remember working with Reign and in pro sport in general. One of the kind of mantras that we would say sometimes when things were getting really stressful would be like, hey, nobody's dying, it's okay. But when it comes to sudden cardiac arrest, actually it can be life or death. So would you mind just explaining what exactly is sudden cardiac arrest, what's meant by that phrase, and what's going on physiologically?
Yeah. Sudden cardiac arrest absolutely is a life-threatening situation, and if it's not treated appropriately, the person, potentially will die. In young athletes, and which is inclusive of collegiate and professional athletes, the causes of sudden cardiac arrest vary. You can have heart muscle diseases called cardiomyopathies. You can have a variety of electrical disorders of the heart. You can have some acquired structural problems like an anomalous coronary, but they all lead to the same issue. And so what sudden cardiac arrest in athletes is really a lethal ventricular arrhythmia or electrical disturbance of the heart, where the heart starts beating super fast from the ventricles, either ventricular tachycardia or ventricular fibrillation, where the ventricles just start to quiver. And in both those settings, you don't have adequate and sustainable blood flow from the heart. And so people will pass out, and with no ongoing blood flow, eventually, pass. And so cardiac arrest is different than a heart attack. A heart attack is when you have a coronary artery that's servicing, oxygenated blood to the working heart muscle that now clogs with like a atherosclerotic plaque that ruptures, and the artery suddenly stops flowing blood. Now that heart attack can lead to a cardiac arrest and an arrhythmia, but not always. And so they're different. And in our young athletes, we're really talking about sudden cardiac arrest.
And I want to get into some of the more common causes of sudden cardiac arrest in athletes in a moment. But first, how common is it? I know you mentioned that it's not very common, but potentially the burden of this happening is quite high, obviously, life or death situation. How common is SCA in athletes, and what do we know specifically about some of the risks in athletes?
Yeah, our best data is probably in our NCAA athletes, where we have some of the better reporting, still not perfect because it's not mandatory, so we're probably missing cases. So the numbers I give you are, if anything, underestimates. But we have a real confined population, so we sort of know our denominator of total number of cases when we calculate an incidence. So the overall risk of sudden cardiac arrest and death in a collegiate athlete is about 1 in 43,000 per year. But we know that some athlete groups are higher risk than others. So male athletes are probably 3 to 4 times higher risk than female athletes. For reasons that we don't understand, black athletes have historically been higher risk than white athletes. It seems that there are some sports that stand out. And so in the U.S., if you take men's basketball and American football, that alone represents over half the cases. And if you add soccer, you're at about 2/3 of cases. And if you add track and field and cross country, you're about 3/4 of cases. And the single highest risk group, again, for reasons that we don't quite understand, is men's basketball. And if you look at the risk in a NCAA Division I black male basketball player, the risk is about 1 in 2,000 per year. And so, I grew up in med school learning that sudden cardiac arrest in athletes was, quote, rare, that it occurred in about 1 in 250,000 to 1 in 300,000 athletes. And that's just wrong. In general, it's actually a lot more common than that. And there are actually some risk groups that are where it's strikingly and alarmingly, frequent, that we have to do more from a prevention standpoint. And so the really low underestimate, or when you hear from, quote, experts and say it's rare, I just can't stand that term because it's not rare. And also when it happens, rare sort of gives someone permission to not do anything about it and not learn about it. So we can move that away. That's just should not be used. That's not what we're talking about. Thankfully, it's not occurring all of the time, and but it can occur, and we've seen it, and of course, we need to be ready for it if it's going to happen in front of us.
And so going back to some of the causes, you mentioned it can be an electrical issue, it can be more cardiomyopathic of an issue. So what are the most common causes in elite level athletes?
Yeah, so the single most common cause that is found either on autopsy or living individuals who survive, let's say, sudden cardiac arrest, is hypertrophic cardiomyopathy. This is a genetic heart disease where the heart muscle becomes thickened and enlarged and asymmetric. It can have some scar tissue, which is like an arrhythmogenic focus. And this is the leading identified cause of sudden cardiac arrest and death in athletes. The causes also vary somewhat by age. And so when you talk about cardiomyopathies in general, and you can add to hypertrophic cardiomyopathy with other types of cardiomyopathies like arrhythmogenic cardiomyopathy, which is where the heart muscle is infiltrated by some fatty tissue and fibrotic tissue, which is very arrhythmogenic. If you add up all the cardiomyopathies, this represents about half the cases in our college and professional athletes. So absolutely the most common. But if you look like young adolescents, like 12 to 14-year-olds, the most common cause is actually something different. It's called an anomalous coronary artery. So they were born with it, and now it presents a problem where the artery sort of gets trapped and squeezed because it's coming off the wrong place. And then you really do get this sort of ischemic type of arrhythmia that occurs with it. Some of those kids will have some symptoms like exertional chest pain at peak exertion, or perhaps even syncope with exertion. And you have to rule out that entity in our young athletes who have those symptoms. So the causes vary. When we screen athletes, one of the more common electrical disturbances of the heart that we find is something called WPW, or Wolff-Parkinson-White, which stands for ventricular preexcitation. And about 1 in 300 individuals will have an ECG that shows WPW. And that doesn't mean that they all go on to have an event or cardiac arrest. But our ability to sort of risk stratify individuals with WPW isn't great. And it has taken a turn from trying to understand risk stratification to really just sending everyone to the electrophysiology lab to really get a very in-depth look at what their accessory pathway might look like and whether or not they should have an ablation. And we identify a lot of cases that have what's called autopsy negative sudden unexplained death, meaning someone dies, we look at the autopsy, there's no apparent cause. So now that reverts us back to, well, maybe this was an electrical problem of the heart that we just haven't identified. Some of those are genetic conditions that we can identify, something like long QT syndrome. But I believe that some of those really are probably WPW just missed, not ever found. And, so we have an opportunity, to identify these conditions before there's a problem and actually to treat them and make them better.
And all of what you're talking about now is really important in, like you're saying, screening and figuring out, is there a way that we can prevent this from becoming an event? So you did mention that there's, more of the acquired risk factors, but then, and potential causes of SCA, but then there's also inherited, and maybe in the younger athletes, you see a higher risk for those inherited factors being causes of SCA. And then maybe later on, it's more of the acquired risks. Is that right?
Yeah, I think that framework in general sort of works. The inherited diseases are cardiomyopathies and ion channel disorders. And, they definitely top the list for our young and competitive athletes. When we talk about acquired heart illnesses, we're talking about things you acquire over time. And so things like atherosclerotic heart disease, which you get really over the age of 30, 35 and above, that becomes the leading cause of cardiac arrest in athletes and just persons in general. Another acquired condition would be something like myocarditis, or an infection of the heart, that you get rather acutely. Commotio cordis would be considered something that's acquired. And so I think when it comes to ischemic heart disease or coronary artery disease, for sure that's considered an acquired condition that is mostly presenting in older athletes.
And so then getting into screening athletes, different governing bodies will have different guidelines in terms of what are must screen or must do things in screenings. Different leagues will have different requirements. What is your advice, or what do you think is really important in screening for cardiac health in athletes?
Yeah, so I've spent a lot of time in this area, and happy to say that there has been a lot of new understanding and things we've learned over time, and really a shift in what's sort of reasonable or accepted or even best practice in this space. I personally do not believe that you can do cardiovascular screening in an athlete without an ECG, without doing an electrocardiogram. It just doesn't work. When it was invented, this sort of pre-participation evaluation, let's ask some cardiovascular symptoms, let's ask about family history, let's do a physical exam in concept, that sort of makes sense. Let's identify people who might have an issue. And it is really important that athletes who have, exercise-related syncope or exercise-related chest pain or a family history of like early sudden death or a family history of someone with an inherited heart condition, for sure we want to identify those people, but we don't necessarily identify them well by like a screening questionnaire where kids, athletes, parents are barely paying attention to it and not filling it out appropriately. And the false positive response rate on those history questionnaires is like 20-25%. It is just not a good tool as a screen, and in contrast, a resting 12-lead electrocardiogram and an ECG, really gives you a look beneath the surface. You have cardiomyopathy shows up 85-90% of the time, is suggested by on an ECG. You find electrical disorders, and in general, if you look at all of the variety of conditions that can lead to sudden cardiac arrest in an athlete, estimates are that an ECG can pick up about 3/4 of them. And so the sensitivity of a history and physical alone is probably at best about 10%. And the sensitivity of an ECG is probably about 75%. And so there's no comparison. There's no comparison. And I just don't think if you're serious about cardiovascular screening in athletes, certainly of the high school, college, and professional ranks, that you can do it well without an ECG. The problem or the challenge is that if you're going to do an ECG, you have to know how to look at it and interpret it and do that well. And you also have to have some resources around you for some of the downstream testing that might be indicated if you have an abnormal ECG. So if you go back 20 years, where we didn't have criteria on how you look at an ECG in an athlete, the false positive rate in those ECGs would be, 20-30%, and that's unacceptable. If you fast forward now to using the international criteria for ECG interpretation in athletes in sort of experienced hands, those false positive rates are like 1 or 2%. And so totally different, much performs way better than a history and physical, is more sensitive, and just provides better information. And so I think ECG to me is the single most important tool that we could use for early detection of individuals at risk. And in the latest American College of Cardiology, American Heart Association sort of, clinical guideline, organizations that in the past were very hesitant to recognize the value of ECG, the language in that guideline has come a long way. They haven't recommended universal ECG, but they have recognized the limitations of history and physical and the added value of ECG when it's done well. And those are really important steps towards making ECG more available and at all levels of sport.
Yeah, and you mentioned one of the key factors there being having someone trained specifically to be able to read that ECG for athletes, because it's my understanding that there might be differences in what a normal ECG is for an elite level athlete versus a standard adolescent or adult. Is that the case, or what makes it different reading an ECG for an elite level athlete?
Yeah, so I think everyone listening to this podcast would all understand the term athlete's heart. That when you train intensely on a regular basis, your heart goes through some physiologic and normal cardiac adaptations to that exercise. Typically, the chambers get bigger, the heart muscle gets thicker, the heart rate slows down, etc. So all of those changes, or a lot of them, can manifest on an ECG with certain findings, and those findings, they overlap with some of the findings that you might see in certain diseases, like cardiomyopathy. And so I think you have to be aware of these physiologic adaptations, not to just overcall all of those as abnormal, and really get more selective on what are the things outside of these physiologic adaptations that sort of overlap with, that could be considered abnormal in someone who's not exercising like that, and get more specific about it. So that's what the criteria do when you use athlete-specific criteria. It recognizes sort of normal and expected physiologic findings in athletes, that we don't have to react to those. We don't have to do more testing. We can recognize those as normal. And then in contrast, we have a list of all the things that are abnormal, really regardless if you're an athlete or not. These represent potential heart conditions, and we need to do more testing.
And so if someone does have an abnormal ECG during that pre-participation screening, what are the next steps, or what are the next levels of testing and assessment that you might do with them?
Yeah, it depends a little bit on what the specific abnormality is on the ECG. That should dictate sort of where it goes. Findings suggestive of a heart muscle disease are usually followed up with an echocardiogram, an ultrasound of the heart, and often a cardiac MRI that looks at just sort of tissue characteristics and better measurements of all the chambers and wall thickness of the heart, and can look for scar tissue. Some of the electrical disorders, go on to see cardiologists and electrophysiologists, and even genetic testing. It sort of depends, I think, on what you find. What we've done in the recommendations for ECG interpretation in athletes, the international criteria, is we have tried to give guidance on what those next steps are. So we very clearly link, we start with, here are all the abnormalities, and the next table is basically, if you have these abnormalities, here are the next steps in the evaluation and the considerations you should be thinking about as a clinician. And so this is really important for me as a team physician, because I can get that evaluation started by just following like that table and those recommendations, as I'm waiting to get that patient into the cardiologist as well to help interpret the downstream testing. And so I think that, sports medicine physicians absolutely can be fully competent in interpreting the ECG, in understanding what's normal or abnormal. Clearly, you can have sports cardiologists involved as well, but you don't have to. You can have a competent, team physician do that. And then if it is abnormal, you can even get the testing started and the workup begun, and have those conversations with the cardiologist as you iron everything out.
And so this is all in regards to, the pre-participation screening. But are there any times where maybe, in the case of myocarditis, which can be from, like a viral infection, is there any time where you then say, hey, we need to redo this screening and screen further, maybe during the season or at a different time other than just pre-participation?
Yeah, so that's really important to point out the difference. The pre-participation evaluation, or the pre-competition medical assessment, or whatever you want to call it, is really this one time a year to make sure you understand your players' medical conditions, and have an assessment and do some basic screening, including, cardiovascular screening. In most cases, these individuals are not reporting cardiovascular symptoms or things like that. So that's a really important evaluation. That is different than the athlete who develops symptoms. And so if you have an athlete mid-season, post-season, whatever, who now has new cardiovascular symptoms, I have chest pain when I exercise, I've passed out during exercise. I'm feeling my heart race, when it shouldn't. I am feeling increasingly fatigued and I can't keep up on the field, like new exercise intolerance. Those are all symptoms that need evaluation. So you would repeat a lot of the testing you would do anyway. You would certainly repeat that ECG. You'd probably follow up a lot of those symptoms with other tests, sort of depending on what the symptom would be, to understand what's going on.
And so now I want to move a little bit from screening into recognizing when it happens in the moment. And so what are some of the classic signs? We've seen the videos, unfortunately, of athletes just suddenly collapsing. But what are signs that you would hope that everyone on the sidelines of a professional or youth sporting event would be able to recognize, like, hey, we need to start treating this as an SCA?
Yeah. So the most important thing to remember to identify sudden cardiac arrest in an athlete is an athlete that is collapsed and unresponsive. If they're collapsed and unresponsive, you have to assume that this is sudden cardiac arrest and just start your emergency response. Call 911, start chest compression, someone go get the AED. There are some other features of sudden cardiac arrest in an athlete that sometimes are misinterpreted, and this can lead to tragic events and delays in that resuscitation. So, we've done a lot of work in this space to characterize the signs and features of sudden cardiac arrest in athletes by looking at videos of everyone that we can find. A good portion of athletes will either stumble, sway, or put their hands on their knees right before they collapse. These are in general non-traumatic collapses, with the exception of commotio cordis, where something hits you in the chest. So non-traumatic collapse, someone stumbles, sways, puts their hands on the knees, sudden collapse. They are unresponsive to verbal stimuli and shoulder tap. Immediately after their collapse, almost half of them will have some amount of seizure activity. So that could be gross myoclonic jerking. It could just be shaking or quivering of one limb, or maybe both arms go up, briefly. All of that is sort of seizure-like activity for lack of oxygenated blood flow to the brain, and unfortunately, a lot of sudden cardiac arrest in young persons is misdiagnosed by lay responders as a seizure. So they call 911, they say little Johnny or little Susie is having a seizure. And unfortunately, our 911 dispatch doesn't take that the next step and say, has a seizure stopped? Are they awake? If they're still unresponsive, is there an AED close? It is really what they should be doing. And often it's like, roll them on their side, help is on the way type stuff, when what they should be saying is, start chest compressions. Is there an AED close by? And another important sort of feature of sudden cardiac arrest in an athlete is what the face looks like. And, the eyes are universally sort of open, with a fixed gaze, or open with the eyes rolled back. And so you come up to the athlete and their eyes are open, and it's sort of an alarming feature, but that's what the face of sudden cardiac arrest looks like. And then if you get there soon enough, they often still have some sort of respiratory or chest movements, and some of this is a remnant of them moving around and exercising and sort of that ventilatory drive. And so if you get there fast enough as an AT on the sideline or something like that, you come up to an athlete who might be twitching or seizing, might still have respiratory movements, might have their eyes open, and it could be sort of confusing. Like, what is this, right? I'm scared, I'm nervous, but I think if we simplify it and just say, this athlete collapsed, and when I get there, they are unresponsive. They are not responding to my shoulder tap or my verbal stimuli. I'm going to assume that sudden cardiac arrest. I'm going to roll them over. I'm going to get them on their back. I'm going to start chest compressions. I'm going to send someone to get an AED. I'm going to make sure someone's calling 911 or doing our sort of all-come emergency sign on the field, and let's go. There is some amount of, time or grace period to assess what's happening on the field, and sort of ensure this person's unresponsive. I think there's confusion about whether or not people should be assessing respirations or pulse. And this comes honestly, unfortunately, from our CPR guidelines, which to me just still have it wrong when it comes to an exercising individual with a witnessed collapse. You know, if you look at the videos of sudden cardiac arrest in athletes and those who have ongoing chest movements, it looks like breathing. And I don't know how you can ask a layperson or a healthcare professional to identify, quote, normal versus abnormal breathing as like the entry point to CPR or no CPR. It makes no sense to me. And so I think athletic medicine and sports medicine, we sort of bypass that. And then also this idea that health professionals should check a pulse. And, you know, I personally, I don't think I would be very confident to really feel like I am certain I am feeling a pulse in someone who's collapsed and unresponsive versus I'm feeling my own pulse. Or I've heard of episodes where you know, good providers are feeling a pulse, but it's an abnormal arrhythmia and they really are in cardiac arrest. And so I don't know if that's very helpful either. Again, just simplify it, get back to collapsed and unresponsive. Now I'm going to move forward. And so, you know, we see in some videos that this response takes, you know, a minute and a half before they sort of recognize, oh no, this is cardiac arrest. And, you know, still that's can lead to a good outcome because you're there very early. But the bottom line is I think we probably have that sort of 15 to 20 second grace period. You know, you get there, assess the situation, take a deep breath yourself that this is what's going on. And then you just got to go. You got to assume this is cardiac arrest and start your emergency procedures.
Yeah, I think the pulse part is what would confuse me the most personally, like running onto a field and trying to check for a pulse. And it's like, it's a chaotic, stressful situation. You might be feeling an arrhythmia, like who knows what actually you're going to feel in that situation. But the AED, if you put that on, can tell you if this is a rhythm that is shockable or not, right? So
Absolutely.
why not just go for the AED?
Absolutely. And, you know, in our young athletes, you know, let's say athletes under, you know, 30, 35, it is universally a ventricular arrhythmia. It's, you know, VT or VF. These are shockable rhythms by the AED. And so if there's any uncertainty at all, like if you're unwilling to start chest compressions or for some reason, at least put the AED pads on. Like that will tell you. And you know, we talk about this in other settings too, where you're not certain if this was a non-traumatic collapse. What if this is a head and neck injury? Like you're not certain. The person is, you didn't see what happened. Let's say certainly that is true for like the NFL and American football. But if that person remains unconscious, you know, before you package them up, like, you know, you got to put the leads on. You got to put the pads on and make sure they're not in arrest.
And so what would the ideal response be? So let's say you're on the sideline, you see a player collapse without contact or with, you know, as in the case with commotio cordis, and you get to them, so they collapse and they're unresponsive. What is the ideal, like, let's go best response?
So, first of all, you have you know, obviously you're talking about like having a healthcare professional on the sideline, like an athletic trainer or a physical therapist or a team doc. You've got eyes on the field. You're watching what happens. You see this player who has a sudden collapse. You know, number one, you saw it quickly. Number two, you're going to get there quickly and you're going to bring your AED with you or make sure that someone running out there with you is carrying the AED. I think when you get out there and you recognize that this person is collapsed and unresponsive, you're going to do your shoulder tap and verbal stimuli, and they are unresponsive. At that point, I think you want to activate your emergency action plan. So the first thing is the all come sign, whatever that is. So if you're at a game, or a different setting that has other people who can come and help, you're going to give them whatever that hand signal is or whatever to as sort of an all come sign. If you're more in a different setting, it might be identifying someone to go call 911 and get help, but you're activating the emergency response system. I think you need to be prepared to begin chest compressions as soon as possible, and that hands-only CPR. And if you didn't bring the AED out with you, you're telling someone to go get it and where it is, and to bring it back swiftly. And so, the ideal response is, prompt recognition, activating your emergency action plan quickly, and then starting chest compressions and applying the AED leads as soon as possible. And once you get the AED leads on and it's ready to analyze the rhythm, you can stop your chest compressions. It analyzes. If it provides a shock, you go right back to the chest and start your chest compressions right away, and go through another cycle or until the person wakes up.
Yeah, and oftentimes there's I guess it is the rule, thankfully, that there's a paramedic on site as well. And so hope for the NWSL anyway is that there's a paramedic on site. And so ideally, athletic trainer, whoever gets there first, is starting this, doing the all call sign, paramedics come on. And it's, I think, an important thing that I learned anyway is that doing the chest compressions can be quite tiring if you have to do multiple rounds of it. And so being able to switch off and communicate, which takes practice. And so what are the best methods? I know at Rain, we did a couple of practice runs with the entire staff. Of course, we had a smaller staff compared to other sports. Women's sports has more limited resources. So we actually even involved Sam, the assistant coach, as part of the EAP. But how would you recommend that teams start practicing and training for this emergency response?
Yeah, so let's talk about like the practice and the game situation, because they're a little bit different. And I think that, identifying roles and responsibilities in an emergency and doing that ahead of time is part of that emergency action plan. And so when you're preparing and rehearsing your EAP for your practice facility, all of your athletic trainers are of course doing it, and your physical therapist, but you probably need other individuals as well. So who is that? Like, who's gonna, if the AED is not pitch side, who's going to run and get it? Who's calling 911? Who's doing a little bit of crowd control with the players? etc. So I think just specifying what the roles and responsibilities are for each individual is really important. And it's absolutely okay to include coaches and strength and conditioning staff and stuff like that. I mean, everyone should be aware of how to recognize this. And honestly, you don't need a medical professional to save a life. You just need someone who knows what they're doing to save a life. The game situations are slightly different, and thankfully, because we just have more help around. And so, now you have, at minimum 2 physicians at NWSL games. You have EMS there and paramedics. You've got ATs at minimum on both sides. And so you've got much, a larger cohort of medical professionals there, but still having that discussion that occurs at really like this pregame medical meeting about 30 minutes before kickoff is really important, because it gets everyone together to talk about what those roles are and what's happening. And, you can imagine a situation where the collapse occurs right in front of the bench and the paramedics are situated, let's say, across, way on the other side of the field. And, if we can get there right, we want to use the paramedics equipment because it accelerates some of the transfer procedures and whatnot. But the bottom line is, if we get there and we think it's SCA and we're starting chest compressions, we're sort of not waiting for their AED. We're going to put on our AED as soon as possible. And I think that's appropriate, meaning that it might take them a minute or minute and a half to get all the way across the field with all their equipment. And so that's still early to have EMS arrive to an emergency within a minute or so, a minute and a half. That's amazing. But when you're really that prepared and it happens right in front of you, you might even be able to do it sooner. And that's okay too. Once the paramedics get there, there's more professionals sort of understanding who's running the code, who's driving the code, and when you sort of pick up and go and get in the rig, so to speak, is also a question that always comes up and is really important. In general, paramedics have a ton of experience obviously with sudden cardiac arrest in the community. This is what they do. They're amazing when you watch them drill on sudden cardiac arrest in individuals. So I think once they arrive on site, for me, like my role would be close communication. I might be someone doing CPR, I might be helping, etc. But I really want them to sort of take over and run the code, and making sure that, from my view, it's like happening efficiently, etc. People always ask, at what point do we, scoop up the person and get in the ambulance and sort of out of public view? And I think this was maybe a common mistake in the past, that you might want to get out of public view, and that's just not right if it's going to compromise the care you can deliver. And so, the message that we always talk about is we will do everything on the field, we'll do everything right there until it seems like it's better for the patient to get in the rig. And so our paramedics can run a code for an hour, out in the field. We don't have to go anywhere. They have everything they need. But it's very possible that at some point it just makes sense, after 2-3 cycles, let's say, of CPR, after those initial shocks, maybe after some initial medications, players got a secure airway, etc., that it's time to sort of package and go and get to the hospital where maybe other procedures can be done. And so that timing, I say, is really up to the people running the code. So it becomes communication on the scene. When is it ready? You tell us, and we'll help, and then we'll get in the ambulance. And so, but these are the discussions that literally occur before every game, at least with us in the NWSL.
And so let's say that a player does have sudden cardiac arrest. They respond well to the emergency action plan, and they come to, and they're okay, thankfully. And this is something we see at Christian Eriksen. And maybe that's a good example in terms of he's playing again. He's come back to playing at an elite level. He's playing professionally. He's playing for his national team. What does it take for a player to be able to go back to high-level sport after that? Obviously, depends on what the underlying cause was. But are there causes of SCA where it's recommended that they probably don't? Obviously, athletes' informed consent is part of this. But yeah, what are you looking for to think that an athlete can get back to sport after this?
Yeah, I'd say it's very individual. And I think that the athlete and the physician and care team want to follow a shared decision-making process where you're doing all the diagnostic tests, you're with the best available sort of understanding and evidence. We can talk about risk, that we can include what the athlete's true sort of preferences and values are about what's going on. Might be very different for a 22-year-old at the beginning of their career versus a 35-year-old who says, I just feel like I'm going to hang it up now. And so with the same exact condition. And not every condition is built equal either. If you have a cardiac arrest with sport and you're trying to go back to sport, with rare exception, you're going to get an implantable defibrillator. And now that you have an implantable defibrillator, while it doesn't prevent you from, let's say, having that potentially lethal ventricular arrhythmia, it probably prevents you from dying. It really provides a very, very good safety net, 99% effective or even greater. And so once they have an ICD, your worry about sort of sudden cardiac death really dissipates quite a bit. And now you're really just talking about a safety network and a good plan and what makes sense, et cetera. And I'm not saying that athletes should be getting ICDs just so they can play sports, or every athlete with an ICD should go back to sport. But from a risk standpoint, it does change the equation, somewhat, and that's important. And so, timeline-wise, assuming there was no cardiac damage, et cetera, you're at least in a probably a 3 to 6 month window before you're beginning exercise again, let alone returning to high level sport. And so it's going to be a while before someone who's had a cardiac arrest during sport is truly back on the field competing. And that's okay. That's what it should be. It deserves some time and space to handle it.
Is there any risk in having that device in a contact sport? Like, can it become affected or damaged in any way?
Theoretically, there's risk that leads can dislodge or the device could be damaged. I mean, they're built pretty hefty. In the ICD registry that's been published, that really wasn't the case, and people are playing sport, even in collision sport like American football, with ICDs, and so I don't think that's a major concern. I think there's ways to pad it so it's protected a little bit, making sure that the athlete feels comfortable with it. And yeah, I don't think that's a major concern anymore.
Okay, well, Jon, thank you so much for all of this insight. I think this will be really important for people to listen to, especially as NWSL and MLS seasons start to kick off. Hopefully, this is something that people can listen to and start to consider their emergency action plans and make sure that they're prepared for an event like this. Because like you said, it's not just a rare thing that we don't need to think about. It is something that needs considerable and intentional planning for it. But before I let you go, I have 2 rapid fire questions I ask everyone. So the first one is, I wish everyone working in women's soccer knew this about SCA.
That it occurs in women's sports and you have to be prepared.
Great. And then the second one is, my favorite thing about working in women's soccer is?
The people. Absolutely the best people in the world, sort of grounded in their community, making a difference, super progressive. Just love women's sports.
Yeah, thank you so much, Jon. I really appreciate it.
All right, Nicole. Thank you so much for having me.